Good evening, EDIC Part 2 aspirants and our honorable faculty. Today's class is about brain death organ donation and ethics, and it would be conducted by Dr. Akhilesh Tandekar. He is HOD in critical care at Apollo Multi-Speciality Hospital, Navi Mumbai. His area of interest are as follows, like DNB critical care, IDCCM, and IDCCN. Over to you, sir.
Thank you for the Academy for this wonderful initiative. Good evening, everyone. Today I'm going to talk on this topic of brain death identification and organ donation. This is very essential and very important topic, and a lot of clinicians have very poor understanding about brain death identification. How do we identify? And in society also there is lack of awareness about brain death identification. So my slides will highlight few important points about the activity about organ donation and how do we identify a brain dead patient, what are the set criteria for identification of brain death. And we'll also try to touch upon the need for organ donation and how do we take care of this organ donor also. This itself is an important chapter on this actually, how to manage a brain dead patient, because if you can't manage a brain dead patient well, the organs that will be harvested will be of poor quality and recipients will have problems. So as we see the global activity in organ transplantation, this is the old data that I have, 2013. The data is not revised data. I don't have the recent slides, but overall, if you see, there is innate need of the organs all over India. If you see the, pattern of a requirement of our organs, okay, the highest organ requirement is seen in Bangalore. Okay, next you will also see that the organ donations that are happening maximum are in Chennai and Bangalore. These are the areas. Okay, and you see there are other areas like Kochi also. A lot of organ donations are happening. And if you see, approximately 2.6% increase in organ donation has happened since last decade or so. But we are just able to meet less than 10% of the need of the organs that are required. And out of which, if we see, maximum organ transplantations are happening in kidney. 41.6% of the kidneys are being transplanted, and only 18.2% of the liver transplantations are happening in India. So basically, the kidney transplantation is very popular, and so basically it is popular because it is also transplanted from the living donor. Okay, if you see the Western culture and Western literature and their healthcare settings, so majority of the organ donations are happening from the cadavers. Whereas in India, we have to be largely dependent upon the living donors. So that's why the kidney transplantations have become popular. Even the part of the liver can be donated by a family member to the patient. And then that's why you see the increase in number of liver transplants have also been seen for a period of time. But heart and lung transplants are such organs, transplantations, where you have to be dependent completely on the cadaveric organ donation. So that's why the heart donations or the heart transplantation, lung transplantations are less, very less compared to the kidney and liver transplantation. So if you see in India, the kidney transplantation need is around 1,50,000. And only 7,500 transplantations have been done. And 90% of them are from the living donors. Whereas in liver, the need is around 30,000. Only 1,400 livers are being transplanted. And, 75% of them are from living donor. And while you see heart transplantation, there is a need of 50,000, patients needing heart transplantations, out of which probably around 100 or less than 100 transplantations are happening, and that too, we have to completely remain dependent on the cadavers. If you see the worldwide data and, outside India, if you see, The organ donations are maximally happening from the Eastern Europe side, okay, or the European side. And the liver transplantations are maximum, if you see the absolute number, which is also higher in these European countries. Whereas, especially Europe and America and Australia also, the transplantations are becoming higher. And then these organ donors are majority from the cadaveric organ donations. They have active organ donor registry, and they have a lot of organ donation awareness programs in place. And now in India, if you see, there are different states where the organ donor activity has increased. Tamil Nadu, Maharashtra, Karnataka, and Andhra Pradesh. If you see in these states, the organ donations have increased. That is mainly because of increase in the awareness. And as far as organ donations are concerned, we have to be completely dependent on live donors, whereas cadaveric donations are less in India. So that's why we have to bring awareness and increase organ donor awareness from cadaveric donation. And the cadaveric donations can be in the form of patients who are brain dead or patients who have had cardiac arrest and they have been declared as having cardiac death. So from these patients, the organ donation can happen. If you see the almost all the organs can be donated, including eyes, skin, tissues, bones, and entire body can be donated for the teaching purpose. If there are no organs, no transplantations will happen. As far as living transplantation, donor transplantation is concerned, one kidney, part of the liver, skin, bone marrow can be transplanted through an authorization process. For this, there is a local committee, okay, which scrutinizes the relatives, and there is another state committee, which is required in cases of distant or unrelated, donors are there. In that case, you have to involve a state level committee also. So, as far as worldwide donations are concerned, Spain and Belgium, you see, the donations are more than 30 per million per year. USA, the organ donations are more than 25 per million per year. UK, 21 per million per year. And India, it is less than 0.5 per million per year of organ donation. So, this condition is really miserable in India, So, 9.2 liver transplants are happening per million in Europe. This is quite encouraging as far as the numbers are concerned. And then cadaveric organ donations in India are largely because we have educational programs. Only those states where the education is maximum, especially in south side, Tamil Nadu, Andhra Pradesh, Karnataka, where the educational level is quite enhanced. So these people have more awareness about organ donations, and then maximum organ donations are happening from these south sides of the Indian continent. And whereas next number is Maharashtra and Gujarat, where the organ donations were around 47 in 2012, and now it has got increased, and almost 80 transplantations have happened as far as cadaveric organ donations are concerned. And we have the least number of organ donations from the northern sides of the Indian continent. And, the total number of deaths from the trauma is, very high, and then these patients, majority of these patients will have traumatic brain injury, severe brain injury. And these patients, as a result of this injury, will also have high propensity to develop brain death status. And then that's why the organ donations can be enhanced through these patients, the trauma being the likely cause of the morbidity and mortality. And the road traffic accidents are very high in India. And you see, and that of 70% of the patients also become brain dead with severe or grievous injuries. And we have the highest rate of head injuries in the world. And if you see in India, more than 1 lakh lives are lost every year. and then 1 million people are already suffering from serious head injuries. And that's why there is a significant potential of cadaveric organ donation in India. And when we see in Mumbai or the other states in Maharashtra, the cadaveric organ donations number has increased. And then we have set a registry, and the registry has set the maximum kidney transplantation, liver transplantations, these numbers have gone up as far as cadaveric organ donations are concerned. So, but for that, we need to have a robust system. There are zonal transplant committees and state level committees which bring awareness among clinicians and try to conduct programs, in the form of CMEs and scientific programs, reaching out to community and reaching out to bureaucrat and administrative people also is very important, because lot many times the bureaucrats are not available or the police is not available. The organ donation, the process which has to go through all these authorities, and the process gets compromised, and there is sometimes a delay or the loss of organs because of the delay in the processing. So that's why it's completely it should be a well-oiled system where everyone is aware of organ donation. And these are the organ donor awareness forms, which are being, given to the families. we know, or the patients with the severe injury. These organ donor forms can also, the organ donor awareness related information is given to these, families in the languages, different languages in the English, and then organ donations can be promoted. So I would like to show this video at the end, if possible. How do we diagnose this brain dead? So as far as the Transplantation of Human Organs Act is concerned, which was amended in 1994, and they have made that, so any patient who has a permanent disability and irreversible loss of function of the brain or brain stem, so these patients are considered as having brain death. So means in these patients, you will see the disappearance of all the evidence of life, which may be in the form of brainstem death or in the form of cardiopulmonary sense. So whenever we have a patient whose cough reflex is lost, or pupillary reflexes are lost, gag reflex is lost, and he doesn't have signs of movement, extremity movements are not there, patient is not breathing. So these patients are likely to be brain dead. Or some patients who have cardiac arrest, okay, the organ retrieval can be facilitated from this patient provided the team is almost all the time ready to receive and resuscitate such patients and proceed with the organ retrieval and organ donation. So as far as brain death is concerned, we get a lot of time. We get time to prepare patients, stabilize patients who is potential brain dead patient who is going for organ donations. We have a lot of times, whereas we don't have a lot of time when the patient has cardiopulmonary arrest and this patient has to go for organ retrieval. We really don't have time. So these patients can be put on ECMO, and then organ retrieval can be proceeded later on. Okay. So as far as brain death criteria are concerned, the brain death is established by documentation of irreversible coma. So patient who is comatose, but he is irreversibly affected. And then these patients don't have brainstem reflexes, or there is irreversible loss of brainstem reflexes, pupillary, gag, cough, nystagmus, loss of auditory reflexes, or some patients who have loss of respiratory center function, or you can document that there is a cessation of intracranial blood flow. So with these techniques, with these documentations, you can consider that patient is having possible brain death. So irreversible coma, loss of brainstem reflexes, or loss of respiratory function, or there is loss of blood supply to the brain. If we can document this, we can say that the patient has brainstem death, brain death. We can call it as brain death. So, but in order to classify somebody as having brain death, we need to be able to establish the cause, underlying cause. Unless the underlying cause is established, brain death diagnosis cannot be proceeded, and we should not, be we cannot be unaware of this fact that in the court of law also and medical legal consequences are also concerned. So there is an observed degree of cerebral dysfunction or loss of cerebral function. Okay, once primary pathology or problem which has led to loss of cerebral function is documented, then we can proceed for identification of brain death. So for identification of patient as brain death, the step one is we need to identify the underlying cause. Step two is to find out confounding factors, the bias factors. Sometimes the brain death situation may as a mimic, may feature as a mimic, especially with patients with the electrolyte dysfunction or hypothermia, or patients of metabolic disorder, or patient has been under the influence of sedative agents or paralyzing agents, or patient has consumed agents which can lead to a comatose situation. So we need to find out and treat these confounding factors, and then we can proceed for identification of brain death. So also we need to, in this situation, these are the confounding factors. If the patient's hypothermia temperature is less than 32 degrees, we need to correct the temperature and bring it to normal. And if the patient has hypotension, BP is less than 100 systolic, we need to make sure that the blood pressure is brought up either with the fluids or vasopressor support. Or if the patient has taken alcohol or poisoning, or he has been under the influence of sedative agents or neuromuscular blocking agent, we need to make sure that the patient is weaned off from this sedative or neuromuscular blocking agents. And if the patient has hyponatremia, hypoglycemia, these factors also need to be corrected. So next, third step is to identify brainstem reflexes. How do we identify brainstem reflexes? So for that, we need to, it has to go through three essential steps. We need to first document coma. Second step is on document brainstem reflexes. And third step is documentation with the apnea test. So how do we do documentation? So, so we need to assess the patient's neurological status with head-to-toe examination. We should have a thorough examination. So generally, Glasgow Coma Score is best, to identify patients' severity of injury or probably comatose state. Can also be identified by giving good painful stimulus and see whether there is any motor movement or not. But also make sure that if the patient is brain dead, these patients' spinal reflexes will be intact. And they may have non-purposeful or spontaneous movements of the extremities. So that should not confound us. That should not be considered as a bias factor and deter you from diagnosing brain death. So that's why. So it happens most of the time that we have identified patient as brain dead, but the patient's limb movements may be obvious, and the family may get confused. They're like, patients' limb movements are there, and still how can we consider them as brain dead? So in that process, sometimes the treatment gets delayed, and the unnecessary treatment gets, advocated to these patients. So we need to explain it to the family that even if the patient is brain dead, the spinal reflexes will remain intact, and that can cause spontaneous movements of the extremities. So this is how you give the painful stimulus, supraorbital, or painful stimulus can be given at the nail bed or at some centers. Painful stimulus is given at the sternal area also. But make sure that while giving painful stimulus, the patient should not have injury to the part which is being utilized for painful stimulus. So that's why whenever a painful stimulus is given, we should see the motor movement. We should also be able to see eye opening. And if the patient is not interpreted verbal response, but majority of these patients will be ventilated, brain dead. So that's why it is very essential to identify the motor movement and the eye movement. So, so basically, as we know, that brainstem reflexes are lost in, uh, upside down direction. So reflexes in the medulla oblongata are the last to cease, but the reflexes from the pons and midbrain and pons will be lost first. So that's why we need to do documentation with the help of pupillary reflexes identification. Check if the patient has absent pupillary reflex, probably this patient is likely to be brain dead. Oculocephalic reflex, doll's eye reflexes. Okay, you keep moving the head and you see the doll's eye movements are there. No. If the doll's eye movements are absent, probably this patient is brain dead. Oculovestibular reflexes can also be a good clue for identification of brain death. So how do we identify with the oculovestibular reflex? Probably we may have to inject a cold saline through the ear and see the nystagmus. Okay, we need to remember the pneumonic cows. If you've given cold saline injection through the ear, and if the patient has nystagmus on the opposite side, okay, and if you inject warm water, if the nystagmus is on the same side, so probably if these reflexes are absent, we can call it as absent oculovestibular reflex. So probably eighth cranial lobe is affected in this situation. And then see corneal reflexes and gag reflexes. So loss of corneal reflex, loss of cough reflex also.